For those of you joining virtually or remotely, we're trying to ensure that you have the ability to come off of mute and be heard. So could someone try that? We've authorized that for Terry, but I see Grant Achenbach or Senator Yoder or anyone else. Give us just a moment here. We're adding the ability for all of our individuals online to speak. So we'll get started in just a couple minutes. Could someone just also drop a note in the chat so that I know you have the ability to do so? So I think only panel, they only have it set up as panel. So I think it needs to be all in these individuals. Could someone try to chat again? We've got quite a few MAC members attending virtually, so I want to be sure before we get started, we have a chance for them to fully participate. So thanks for your patience.
Or Senator Yoder asks to see her responses to your questions.
No.
No.
So but what we're doing right now is adding each attendee into the panelist category so that everyone's able to participate. So I can see people popping up one by one. I see Zoe.
Once you've added her.
Once we've added her, she will be in. So just another few minutes here. Thank you.
Sure.
For those of you who have joined remotely or virtually, what we're doing is adding you as a panelist to the Zoom so that you're able to speak and come off of mute and chat. You should receive a pop-up box that says accept promotion. Congratulations on your promotion to as a panelist. So please accept that so that we can add you. Thank you. I see our list is growing of panelists, so this is a great thing. So again, if you're just joining virtually and you are a MAC member, you should be receiving an invite to be a panelist. A pop-up should appear on your screen. Please accept that so that you have the ability to come off of mute and to chat. So Senator Yoder, could you perhaps test to see if we can hear you?
Test, test. It's
Great.
good to be together.
Thank you.
Thank
right.
you.
Just a couple more minutes. I see the list growing. Thanks again. For those of you in the room, if you prefer to follow along with the slide deck, we do have handouts and copies of the slides. We'll also get it put back up on the screen. Okay, I think we've seen it slow down now, so we should be good to go. A quick note, I think the Zoom link is for MAC members or for those that are presenters as a state employee or another guest presenting. For those of you who are not MAC members, you can access this presentation and meeting online at the YouTube link. So just want to clarify that because I think we have some folks in the Zoom who may be members of the public. You can go to the FSSA YouTube link and see that there. So just making sure that that's clear for everyone. Okay, I think we've got, if you're not able to speak yet, they're working on it and you should be very soon. Again, if you're just now joining, please accept that pop-up box that offers you being a panelist. Again, if you are a MAC member or a proxy for a MAC member. I will turn it over to Terry Cole, who is chairing the meeting.
Okay, all right. Can you all hear me?
Sounds great.
Okay, perfect. Thank you. Thank you all for joining today. We will go ahead and call the meeting to order. It is 10:10, so the meeting has now been called to order. The first item on the agenda today is the approval of the minutes from the August 2024 meeting. Are there any comments, questions, or changes that anyone need to be made to those minutes? You all should have received the minutes a while ago, so just want to check and see if there are any thoughts on changes or comments. If not, I'll ask for a motion to approve those minutes. And I can barely see the room. So if someone is responding in the room, I think I might have to rely on you, Cora, to let me know.
Great.
Okay, and so do we have a second?
Second.
Thank you. And so I will ask for all in favor of approval of those minutes.
Aye.
Any opposed? Okay, the minutes are approved. The first item on the agenda today is a rulemaking update, and I will turn it over now to Amanda DeRoss for that update.
Good morning, Amanda DeRoss. I just have 3 rules to present today. LSA 24-326, the EPSDT rule. LSA 24380, which is the calendar year rule. And LSA 24-419, which is the pharmacist rule. So as usual, I'll just give you a brief overview of the rule and where it's at, and let me know if you have any questions. So the EPSDT rule, which again is LSA 24-326. This proposed rule adds and amends rules at 405 IAC 5 to replace references to the early and periodic screening, diagnostic, and treatment EPSDT periodicity schedule. So the rule was actually submitted to the Office of the Attorney General on November 1st of this year for review and approval. And once the Office of the Attorney General reviews and approves the rule, it will be submitted to the Governor's Office for review. Second rule is that calendar year rule, which again, LSA 24-380. This proposed rule amends rules at 405 IAC 5 to update the language concerning reimbursement of certain services used by different systems. A public hearing was just held last week on November 13th for this rule, and at this time, OMPP, along with OGC, the Office of General Counsel, we are reviewing and preparing potential responses to public comments. And last, we have LSA 24-419, the pharmacist rule. And this proposed rule amends rules at 405 IAC 1-11.5-1 to include licensed pharmacists as a provider type under the list of non-physician practitioners. So a notice of public comment period and hearing was posted on the Indiana Register on October 30th of this year, and a public hearing for that rule will be held on December 2nd. Does anybody have any questions? Will there be, Sarah Boss, will there be opportunity for more discussion on understanding of how I guess, can you clarify the questions? What that how the right people decide what are the thinking of most of them, but and then also how that affects other programs. Some of that I will leave to more of like a subject matter expert. I can tell you that what the rule change did is the rule previously had an outdated periodicity schedule kind of incorporated into it. And we knew that that was outdated. So we replaced it with just a reference to the current one. And then it states that the current one has to be followed or a more recent one can be followed if the new one has been updated, since I think they updated. So I can tell you that much. As far as how it interacts with other programs, somebody else. Can do that.
Are there any other questions or comments? I will ask if the folks in the room could make sure they use a microphone when they speak. It's difficult to hear, I think, for the people who are online.
Well, if no other questions, that concludes my rule presentation.
Okay, thank you. So we next will move on to a public comment period. This is for the substance abuse disorder and serious mental illness 1115 waiver renewal. Do we have folks who have signed up to provide public comment?
Thanks, Terry. This is Cora. I'll just jump in. So we just have a very quick slide here. You'll recall at the last meeting, we presented our annual review of the 1115 waivers of both the Helping Indiana plan and also those substance use disorder and serious mental illness waivers that are attached to that. This is a waiver that allows us to provide services for individuals ages 19 to 64 in institutions for mental diseases. Typically, that's excluded by federal law. And we also will be using this waiver to comply with a requirement that we provide coverage for former foster youth who have aged out of the foster care program in other states and reside in Indiana. So this is simply an opportunity for public comment. We won't be responding to questions. The full documentation is available online at the FSSA public notices page. So this is our second public hearing. A public hearing was also held last Friday. Comments can also be submitted by mail and email, and that is reflected here on this slide. And I think as of this time, we do not have anyone signed up for public comment. This will be a 5-year renewal, no significant programmatic changes submitted, but we'll go to CMS at this time to extend the program from January 1, 2026 through 2030. Any other public comment?
This is Dr. Heather Fratwell from Indiana Psychiatric Society and Eskenazi Health. I would like to make a public comment in full support of this extension and with appreciation for the thoughtfulness and consideration. Thank you.
Okay, thank you, Terry.
Okay, that's it. So no more.
Cora, this is Zoe with the Indiana Council. And so the Indiana Council also, along with Dr. Fretwell, supports the waiver. Just to emphasize the importance of this amongst substance use disorder services, our community mental health system served over 50,000 lives on an annual basis as a result of this waiver. And our total annual Medicaid lives served is over 181,000. As a result of these services and the other efforts, Indiana was one of the few states to decrease overdoses this last year. And so that is something I think the work of this waiver and the work of the state should be proud of, as well as our system. And many levels of care for both SMI and substance use are accessible statewide as a result of this waiver in the community mental health system.
Thank you, Zoe. That's great. Are there any other comments from either public or MAC members? I will add that the Indiana Hospital Association is in full support of the extension also. So I don't know if that's appropriate for me to say at this point in time, but we are definitely in support. Okay, if nothing else, going once, I will go ahead and move then to the next item on the agenda, which we have a couple of presentations today. The first one is Lindsay Potts. She's going to do a presentation for us on the CCBHC program and provide an update for us. I'll turn it over to you, Lindsay.
Thank you. Can everyone hear me okay? A little bit louder, use my theater voice. Got it. So hi, everyone. Thanks for having us here today to discuss the Certified Community Behavioral Health Clinics expansion and also an update on our 988 and crisis response systems. So on to the next slide. So what is CCBHC? It is a long acronym that it signifies a transformation in our behavioral health care system. And so this was catalyzed by the Senate Ruled Act 1 of 2023, which included both the CCBHC model for Indiana to become a part of the Medicaid demonstration, but also included our 988 crisis response system expansion as well. And so what does CCBHC do? It ensures access, which is also to that crisis response 24/7, but also meets strict criteria regarding quality, reporting, staffing, coordination with social services, justice systems, education, and beyond. It also receives funding to support those services that reflects the real cost of providing behavioral health care in this new higher quality way. Next slide. There we go. So who can access services? So this is anyone who requests care for mental health or substance use disorder, receives services at CCBHCs, regardless of their ability to pay or where they live or their age. So this is a lifespan model for behavioral health care. And it, to call out, also includes care for the youth and children. And so the 9 core services are listed there. To call out a couple of these, crisis services is one of the critical services that are expanded here and funded through this model. Also, peer family support and counselor services. Peer services are critical access or critical service for those experiencing substance use disorder and beyond for engagement. And then the community-based mental health care for veterans is also a critical aspect here to serve, to provide and expand services for those who have served the country. And then also just the outpatient mental health and substance use services and integrated care is also built into this model. Next slide. So why is the transformation important? And so this speaks to specifically what are the enhancements that we have. So currently today, there are many structural barriers in place that keeps behavioral health services siloed from the rest of healthcare and from our community systems. And so this new model establishes standards for how behavioral health is required to be integrated throughout all of healthcare and also throughout community services that support individuals with behavioral health needs. It moves from a fee-for-service model that drives quantity to a quality-based model that focuses on outcomes and that return on investment. It also allows for the customization of needs for the individual receiving care that can sometimes expand beyond what is available within the fee-for-service model. Also, staff turnover is very high in behavioral health service delivery, especially in a lot of our systems. And so this allows for there to be the competitive payment or to retain those critical key staff members that are essential to a high quality system. Next slide. So what is the transforming reimbursement structure here? So our current community mental health system is comprised of multiple funding sources that come together to create solvency for behavioral health care delivery. CCBHC looks to simplify that into one PPS 1 daily rate payment that allows to simplify not only payment but services. So the individual receiving care receives a consistent response from our CCBHCs that has the specific requirements for coordination, access to services, and is a one-stop shop for all of their needs. But as you can see to the left right now, those different the other funding sources cobbled together to meet the needs right now, which creates a lot of inconsistencies and some issues with solvency within our current system. Next slide. So the road to the Medicaid demonstration. So we had marching orders to get a demonstration application in place. And so we issued an RFI and an RFS, request for information, request for services, to competitively procure the initial sites that would be a part of Indiana's demonstration for CCBHC. 8 sites were chosen through that competitive procurement, and those were based off of readiness. And so we had 27 applicants. We then completed the Medicaid demonstration application, which included those 8 sites, but also beyond from a state readiness perspective. And Indiana was selected as one of the next 10 states to be a part of the CCBHC Medicaid demonstration. And so we have been actively working towards go live, which is set to start in January 2025, coming up very quickly to make sure that our system is ready to go. The next slide. You can see the CCBHC demonstration footprint here. So through the competitive procurement, we got a nice footprint of urban, suburban, rural. And so these 8 providers, as you can see there, are working to implement the model, which is a very high bar to reach. So there is extensive certification criteria that these providers have to follow and demonstrate through a designation process. They also have to have their data systems ready because, as we already mentioned, this is a quality-based program. So the data requirements are expanded beyond what they are today, and also to allow for that additional access for crisis response system and the other services that they're growing and expanding. So next slide. So how are we tracking this progress? And so through that data, we have the goals for this program. So we call out 4 specific goals that are regarding quality. And those goals are the timeliness to access, our social drivers of health screening, the substance use disorder treatment initiation, and then the access to crisis services, which align with a lot with the other goals that the Division of Mental Health and Addiction has been working on with other projects. We also calling out there the service mix goals, and we want to see those 9 core services that we called out, starting to see those expand beyond what they are today. Some of those are newer services or services that are provided at a small quantity that CCBHC allows for expansion of. And so we're monitoring those and are setting stretch goals for our system to really reflect what our individuals and communities need for behavioral health care delivery. So you can see how we're tracking that data through our Dharma system there, which is the data assessment registry, and our Medicaid claims data are the 2 data sources for that. Next slide. So to transition a bit into narrow our focus into the Indiana's crisis response system here. So our 988 is the national 3-digit suicide and crisis lifeline. We went live in 2022. And the team has done a phenomenal job of implementing this in the state of Indiana. We'll highlight some of those wins here in a minute. But just the 3-pillar system, a snapshot here is the someone to contact, someone to respond, and somewhere to go. So this expansion has been critically important over the last 2 years connected to 988. We've had exponential growth in access for these services throughout the entire state, and also is an important access point for individuals with behavioral health needs. So as is today, our first responder system, criminal justice, hospital systems, a lot of times are those safety catches for individuals in behavioral health crisis. And this creates other options for who responds and where they go. And so this is also a critical part of our CCBHC rollout and has been rolled out in tandem together intentionally to make sure that as CCBHC is implemented, the crisis response system is strengthened and supported. Next slide. So our progress on pillar 1 here. So this is 988, that's someone to call. You can see the exponential growth that the 988 line has had over the last year. And we've seen it just skyrocket. So the good news is our answer rate has stayed in the top 10 in the nation. All of the call centers that take 988 calls are in Indiana, and they have to follow strict requirements that are federal and based off our state needs. What we're doing next, though, is this next level of integration into our crisis response system that is our emergency management system. So how does 988 interact with 911? How does 988 interact with communities and individuals in crisis as well? And so we're engaging our 911 and first responder network. We're intentionally integrating this into CCBHC. We have a community stakeholders and crisis provider network that is fully engaged as we grow the system to iterate it over time to customize it. What is something I think is unique about how Indiana has rolled out specifically not only 988, but our crisis response system is it is a high bar, it is consistent, yet it is community focused. And so we have engaged community providers to provide the services to the communities they serve versus other states have implemented this as more of a centralized response. And so we've taken a different approach that lines up with Indiana's approach to the community level. Next slide. So this is our progress on pillars 2 and 3. So you can see kind of the amount of catalyzed growth that we've had over the last year and a half or so. And we are actually expanding even beyond this. We have 2 additional sites that are designated for that mobile crisis teams. So you can see the mobile crisis teams there in green. We have almost statewide access. As of yesterday, we are above the 90% threshold of access to a mobile crisis team in the community. This does not mean that we are at full saturation. So full saturation of how many teams does a community need, that is still something we're working on. But as far as a team being in the community available to serve those individuals, we're above that 90% threshold. The stars there are the crisis receiving and stabilization services expansion, which is really marked in this exponential increase throughout the state. So these are facilities where individuals can be dropped off by law enforcement, can walk in the door, can be brought in by family members that are not the emergency department, it's not the hospital, it's another place with specifically trained individuals and peers, individuals with lived experience on staff there to help manage a crisis. And so this has had a substantial impact throughout the state as an alternative to jail. It's an alternative to the hospital and ultimately is a more trauma-informed approach for individuals experiencing mental health crisis. Next slide. And so the future of CCBHC and crisis response. And so this visualizes the importance of these 2 initiatives being rolled out in tandem together, is that CCBHC offers the sustainable and scalable fiscal system to support the crisis response system. So as we have today, the crisis response system has been infused with community mental health funds from that Senate Enrolled Act 2023, that initial startup funds, and then CCBHC is the bridge to the fiscal solvency for the crisis response model. But it's not just that. So crisis, right? We want a crisis response system that meets individuals' needs, but ultimately we're seeing less people in crisis. And so that's why it's critically important to have the certified community behavioral health clinic model, which has a high quality of services beyond crisis. So that way individuals don't have to reach crisis to get what they need, that they have what they need right when they walk into the CCBHC, and that we start to see those crisis numbers go down over time. I believe that is it. So can you answer any questions if that's happening?
Thanks, Lindsay. Are there any questions from anyone, any members of the MAC?
This is Sydney Moulton with the Council of Community Mental Health Centers, not a question, but a comment. We just want to say thank you so much to DMHA and their leadership for helping shepherd this along. Our members are extraordinarily committed to the future of CCBHC and have invested a lot in infrastructure and workforce in order to see this through. And so we're just very excited for the go live date and the promise that it brings for the future. So thank you.
Thank you. That's great. Zoe, I think you looked like you had your hand up for a second, or?
I just second all that.
Oh, okay.
Carrie, Representative Shackelford has her hand raised in the room as well.
Oh, okay.
Okay, thank you. Thanks for the great information. I think this is a very important program. I have a quick question because I constantly get asked by constituents, when is the state going to be looking at an inpatient mental health facility? Do we have any inklings on that, or are we working towards that? Or can anyone answer that?
I will have to defer. I think the inpatient work is outside the CCBHC model.
And I guess Representative Shackelford, your question is about an inpatient mental health facility. So we do have the state psychiatric hospitals. I guess, can you say a little bit more about what you are inquiring about?
So they're wanting to see more inpatient facilities. I do see these are moving towards, so we're coordinating the outpatient. But are we going to work on, or are we working on any further communities, any further facilities for inpatient?
So I can speak a little bit. We also have our interim director of DMHA here as well. I think one of the things that we are trying to do with our substance use disorder and serious mental illness 1115 waiver that we just had public comment on at the opening of this, we've really have seen an increase in access to services across the continuum by having that SUD and SMI 1115 waiver in place, because it allows us to receive federal reimbursement for those inpatient settings that typically you can't. And so I think that we presented some information at the Commission to Combat Substance Use Disorder last week, and really the data of those particular evaluations show an expansion in this space for providers really from inpatient, but then again, we're also focused really intensely about ensuring that those that can and would like to be in an outpatient or community-based setting, we're supporting that work as well. I don't know of any plans specifically for a state-owned and operated facility, but definitely we're supporting providers as they, I guess, take on both inpatient work and outpatient work. Becky, anything you want to add to that?
No, so Becky Buhner, interim director at Division of Health and Addiction. No, Corey, yes, you addressed it, but thank you.
Thank you. Okay, I'm sorry, I missed you down there.
Hi, it's
Hundley.
Senator Hundley. Thank you so much for your comments and for your report. Really appreciate that, Lindsay. I think my question really is a follow-up to what Representative Shackelford was asking, and maybe it is for Director Buhner, but about those private mental health institutions, because we're talking about those crisis receiving stabilization centers. Would those private mental health institutions fall under that category?
No, they are certified different than the crisis receiving and stabilization has an hourly limit, which is under 24 hours. So whereas the private mental health institutions are more of a anywhere from 3 to 10 day stay.
And then you said they're certified differently. And so who is responsible for certifying the crisis receiving stabilization?
So DMHA, we are responsible for that designation.
So responsible for the designation both of the CRSS and the private mental health institution.
Yes, we also partner with Department of Health for the licensing of some of the hospital units.
Thank you for clarifying that. I think that one of the concerns that we know that has bubbled up when we're thinking about, the people that we're taking care of, that when they're in these crisis states, they're so incredibly vulnerable. So we want to make sure that they're receiving high quality of care, of course, and a high level of oversight and accountability. And so for the crisis receiving stabilization centers, what is the process for annual evaluation, for ensuring that patient care is up to standard? What does that look like?
Yeah, thank you for the question. And so as we've expanded this innovative model and are using federal guidelines, so there's federal guidance that is still pretty broad in this third pillar, as we call it, which is for Indiana crisis receiving and stabilization services. Other terms have been crisis stabilization units. But it really is that additional place to go. And so all of our guidance has been within that framework. However, also understanding that we don't quite understand it 100% yet, right? So it's kind of hard to build in the strict regulatory until we get a better sense of what the communities need. So we're not restricting access. So sometimes inadvertently, we can put in a regulation that then makes it harder for somebody to receive services because they have to check X, Y, and Z box. And so we've been working monthly. We have a working group with all of the providers that are helping us build this together to help understand what are those communities' unique needs for this level of care, because it is a different level of care than we see in the inpatient psychiatric unit world and in the emergency department. It's filling that gap between that psychiatric emergency where there's a level of safety and threat concern versus what is that psychiatric crisis that really needs just a safe place to be and people to listen and to support to help de-escalate and then move into an outpatient setting. I think everyone has worked with individuals in crisis and appreciate the importance of keeping individuals in community in that least restrictive environment. And so we're building the parameters of this right along and are right midstream with developing our additional rule around this and how is this really going to operationalize from that accountability standpoint. So we're getting there, but we're getting there from a community informed.
I appreciate that. And I appreciate you emphasizing too the level of collaboration that's going into, going into designing the system, right, as we're building it. And I would love to see collaboration further, not on regulation per se, that's going to create additional red tape. Lord knows we don't need more of that. But collaboration on designing out a system of oversight. So what does that look like with the number of site visits? Who's doing site visits? What are we reporting on? How do we have a transparent reporting system? I think that building that in right now is going to be critical to, setting our baseline standards and then making sure that we are, have something to compare those results to later on. So thank you so much.
No, that's really helpful feedback. Thank you.
Representative Garcia Wilburn, that's my hand.
It's on that same vein. So it's kind of, at one kind of time ago, DMHA certified providers had to be accredited by the Department of Justice. Is that still correct?
Yes,
So there already exists a high level federal regulation.
correct. Yes, all of these facilities have to meet those requirements.
Are there any other comments, questions? Okay. Thank you, Lindsay. We will move now to the next item on the agenda, the Pathways for Aging implementation update. And we've got several folks who will be presenting. The first is Holly Cunningham Piggott from OMPP, and I believe she will get started on this. And then Holly, I'll let you turn it over to the next speakers as we move through this. And I don't know if we want to take time for questions in between. We can do that. Just let me know.
Okay, thank you. Good morning, everyone. And I'm sure everyone's here and happy to hear about Pathways. So I'm happy to give you that update. We brought some friends with us today to share some of those updates. And those friends are managed care entities. And so they will be presenting some slides on what they're doing and how they're doing it and how to get in contact with them here in just a little bit. Oops, I'm going the wrong way. Okay, so just a quick kind of summary. I know we've kind of gone over this in these meetings before, but Pathways is a managed Medicaid program that helps support individuals that are 60 and older and also living maybe in a nursing facility or receiving home and community-based services through a waiver like the previously known as the A&D waiver, now known as the Pathways waiver. And we procured a contract with 3 insurance companies, which were Anthem, Humana, and United Healthcare, to help us deliver these new managed Medicaid services to those individuals living in those environments. Next slide. So this is just kind of a summary of where we're at with enrollment by MCE. Right now, we're roughly at 117,000 Pathways members. And if you look at the bar graph there, you will see how that membership is distributed among the managed care entities. Now, to be to win our contract, you also had to have, be approved to provide Medicare Advantage, D-SNP services in the state. And so, we have 80% of our Pathways population who are duals. So they are in some sort of Medicare, whether it's a D-SNP, Medicare Advantage, or regular fee-for-service Medicare. But we've run some numbers, and about 50% of our duals are assigned already in a D-SNP program with one of these MCEs. Next slide. So just some updates on claims is obviously is a big issue for providers. It's a big issue for members because if providers aren't paid, then they're not providing the services. And so we have been working really diligently with our managed care partners, and they have been working diligently with their teams to make sure that we can meet the expectations of providers, then that will also then kind of trickle down into making sure members are receiving services. To do this, then we receive weekly reporting from our managed care entities on how they are paying claims. Are they paying claims? What's the percentage of adjudicated claims? What's the percentage of denied claims? And so this has really helped us keep the pulse on how they're doing and where they're at with the claims process. We also put together, prior to going live with Pathways, which was July 1st, we put together a provider work group, which really consists of the provider associations getting on a call with us monthly so that we can talk about what their members are experiencing, negative or positive for that matter, so that we can go back to the managed care entities and address those issues quickly. We also have our claims advisory committee that was, mandated through legislation passed last General Assembly, 2024 General Assembly. And we were meeting weekly. We've moved that to every other week. And hopefully at some point we'll move to monthly, and then eventually we can kind of maybe phase out that committee. But that committee has representatives from all the different LTSS provider types. So home health care, hospice, HCBS services, nursing facilities. And that's really another way we're keeping the finger on the pulse. They come back to us because they're actually providers experiencing these issues. And we have the managed care entities on the calls with us, and they're able to hear real time, real life issues that the providers are experiencing, because we know if these providers are experiencing it, then probably the provider world as a whole is also experiencing it. And so they're able to take that feedback back to their teams and work on correcting those issues. We've also established regular meetings with, we've actually required the managed care entities to establish regular meetings with the different associations. So, prior to, we were talking regularly as OMPP with associations, but the MCEs we were kind of in the middle of some of those discussions. So we kind of pulled ourselves out of that discussion and required the MCEs to start having weekly or bi-weekly, bi-monthly meetings with those different provider associations. So, the Nursing Home Association or the Home Health Care Associations, the HCBS Association. So they're meeting either weekly or every other week or monthly with some of them, so that they can make sure that they're staying on top of provider issues. Another thing that we've done is because we experienced some claims issues out of the gate, normally timely filing to submit a claim is 90 days. And we extended that to so if you had claims in July, you would have needed to submit them, by September to meet the 90 days. We extended that to October 31st, and then we realized that we were going to need to extend it again. So we extended that out again to December 2024. And if we need to reevaluate and extend again, then we will make that decision internally. I mean, we're listening to our associations. Again, they're telling us what they need so that their providers can get paid. And then, we're taking that information
and making decisions based off of the feedback we get. So a bulletin was published. I think it was actually sent out on November 1st, and there is the bulletin reference number in this slide. So the next slide is just a aggregate of data. So we get weekly reports with this data. We have compiled the weekly reports into so that you can see kind of a snapshot from August 19th to November 1st. This is how the MCEs are performing regarding claims. We definitely aren't where we need to be. We know this. And they're really working tirelessly to get these things corrected. We actually have implemented face-to-face meetings with a couple of the MCEs so that we can get real-time updates on these things and then relay those out to stakeholders, because, you know, that's the other thing too, is waiting, not hearing anything, waiting, not hearing anything. And we want to make sure we're giving timely updates to the provider community so they understand that we are listening to them and that we are working on these items. But as of today, for 21-day adjudication, you can see here where we have Anthem for professional, and then Humana and UHC for facility and professional claims are meeting the timely adjudication that requirements in the contract, which is 21 days. Anthem is missing right now with facility, but you can also see that they've paid over $10,000 in interest, because if they pay outside that 21-day window, then they have to, those claims start accruing interest. So if they don't adjudicate, I back up. It's not necessarily that they have to pay, but if they don't adjudicate that claim within 21 days, then they have to start paying interest on any outstanding amount. So, so Anthem is accruing interest on those claims that they have not paid within 21 days. And we can see that here because they have to report that out as well. Next slide. It's part of the legislation that I talked about earlier that was passed in the 2024 General Assembly. We were required to develop a program that we call a temporary emergency financial assistance program. We know that there's a lot of small providers around Indiana, especially providers that serve our rural areas. And we need those providers. We can't have those providers going anywhere. But we also know that we were going to encounter some claims, hiccups along the way. So we developed this program where if providers participated in our claims testing in April and May, then they could be eligible to receive some financial assistance if they were having claims processing issues with the MCEs. We started receiving applications after go live. We've received 275 applications to date. We've approved several. The MCEs have made several financial payments to different providers. The other piece of this too is that the MCEs have even gone further with this. And if the provider did not meet the criteria of this program, they're actually working one-on-one and providing financial assistance if needed because the big thing is we need our providers and we need to support them as much as possible. And so we have this program, but the MCEs have kind of taken a step outside of this and taken it a step further and are helping providers as well that aren't eligible to participate in this program. The other unique thing and I've talked about this, I think, before in MAC meetings, the Pathways contract called for an independent third-party kind of customer service requirement that we're calling member support services. So we procured a contract with a vendor who has a call center. So they're outside of the managed care companies so that members had a third party that they could call if they aren't getting they don't understand what the managed care company is telling them, or if they're not getting what they think they need, or maybe they need to file a grievance or an appeal. And so
Our vendor has our member support services call center. And they provide, advocacy. They will get on three-way calls with the managed care companies to help explain things to members. They will help members file grievances and appeals. They educate them on managed care. They actually will even go face to face if the member is having issues and meet with folks in the community so that they can work. Because sometimes talking on the phone does not work for those folks. So they will even go and meet them face to face if they need to figure out what's going on and help them work through that. Our top call reasons for our member support call center is individuals calling because they need to know about their care and service coordination, or have questions about benefits or access to benefits. They maybe just have general questions or inquiries like, how do I even know who my managed care company is? That's a pretty typical question that comes in. Eligibility questions. So maybe this has nothing to do with the managed care company. Maybe it has to do, they got a letter saying that that they no longer have Medicaid or their Medicaid is going to end. Our member support services will help them kind of rectify or find answers to those issues. It doesn't have to necessarily do with the managed care company. If it has anything to do with any of their Medicaid managed care or not, the MSS team, the member support services team, will assist them. They also escalate issues to other agencies. So, if someone's calling and saying that maybe they had some sort of natural disaster and have no power and need to find temporary housing, they'll help go through 211. They'll make a referral to 211 and work with 211 and the member to help them resolve those issues. They may make a referral to wherever that individual lives to their local area agency on aging, or they may make a referral to the Division of Family Resources if it is an eligibility or Medicaid issue. The one thing that is really unique and one of the things that I'm proud about with the member support services team is that they don't close any case. So they may have done a one-call resolution, but they always call back within 5 business days to ensure that that member is still okay with the resolution and there's nothing new. Or if it was a referral to an outside agency, making sure that the outside agency circled back around and is working with them. So the MSS does not close any loop until they do that final call and check in with the member to ensure that they got what they needed. And I put the contact information for MSS in here because we want to make sure individuals that are on the Pathways program are aware of this program. We try to get the word out through our managed care companies. We try to get it out. MSS does some, I would say, some marketing where they go out and make sure people understand what their role is. So that their contact information is on here.
I'm sorry, Holly, was that your last slide?
No, I'm gonna, their next slide is the waiver waiting list updates. I'm gonna let Cora talk to the wait list.
Thank you. So this is related to the Pathways program, but again, we want to just make sure we're very clear at the outset that there is no waiting list for the overall Pathways program. So the updates that Holly just shared are with regard to the Pathways program as a whole. This information that we're going to share really in follow-up to some questions we received at the last MAC meeting that we want to be responsive to is just with regard to the Pathways waiver. And we've also included information about the health and wellness waiver. So just want to be clear, no Pathways with program waiting list. So as you are aware, we implemented a waiting list as we exhausted slots in April of 2024. And then effective July 1, as the new waiver years began, and really that was on the historic aged and disabled waiver, which then, as you'll recall, split into 2 different waivers based on age. Individuals 60 and up went to the Pathways waiver. Individuals under 60, this health and wellness waiver. We began issuing invitations off of the waiting list and onto the waiver. So wanted to provide an update. This information is available on the BDRS and OMPP waiting list website. So it looks a little bit different. We just formatted it to fit better on this slide, but this information all exists there. For the months of July, August, and September, we issued 800 invitations on the Pathways waiver and 125 invitations on the Health and Wellness waiver. We increased that in October to 1,200 Pathways invitations and 500 Health and Wellness invitations. And then last week we issued our November invitations, and on the Pathways side, increased that to 1,500. You can see we also have on this slide the total number of individuals on the waiting list, since that's a question we frequently receive, as well as the number of individuals who have been invited off of the waiting list in aggregate. A question we frequently receive is, when will I receive my invitation? Which, as we've explained at the last meeting, is a challenging date to pinpoint because of the reserve capacity categories and the prioritization of certain individuals who meet the waiver priority categories, which include those exiting care from a hospital, a nursing facility, or transitioning off of a state-funded program, which is the choice program. So to better paint a picture for individuals around when they might expect an invitation, what we've started doing is publishing the last level of care date that an individual that results in an invitation. So if an individual is not sure of their last level of care date, that information is something that they can obtain from their AAA, or Area Agency on Aging, who does that level of care determination for them. So by that, publishing that type of information, which will be updated each month on the website as we release new invitations and we adjust the counts of invitations that have gone out in the aggregate, individuals can have a better picture of how far along through the wait list we've been moving. We've also published here the number of total approved slots on each of the 2 waivers, again, since that's a question we frequently receive. So wanted to provide this, also give you an update that there are a number of what I think are very helpful new frequently asked questions around the waiting list that we've published on the website. The teams at FSSA, really across the divisions and in collaboration with our communications team, been very thoughtful about helping provide additional resources and information about what to expect through that waiting list process. We've also been monitoring data really closely about how waiting list invitations yield enrollment and the process by which individuals have to go through their functional level of care determination to ensure functional eligibility, as well as their Medicaid financial eligibility. Wanted to provide a quick update on that for you as well. This really concludes the FSSA portion of the Pathways update. And so we can carry whatever your preference is. We can either go forward with the MCE updates, or if we want to pause for questions, I think Polly and I are flexible.
Well, we do have one question in the chat. I don't know, is it possible to go back to the slide that shows that had the claims payment percentages on it? Yeah. Rodney, I don't know if you're able to come off of mute and speak, or do you want me just to read? The question that's in the chat says, why are Anthem facility claims only 78% compared to the other 2 providers with 98 and 99%? That I think is down on the paid with interest question.
Yeah, so Anthem has experienced some issues with it's a handful of different issues that have been denying facility claims. They are required, as a result of these numbers, to do a root cause analysis and address what the end-to-end issues are. And they're in the process of doing that. In the meantime, they are manually pushing through claims that will deny because of some of the different reasons. Sometimes there's a explanation of benefits that is needed from Medicare, but there's certain services that shouldn't impact. So there's some systems issues on their part, and they're pending those, reviewing them, and then trying to pay them manually so that they don't go back as a denied claim. But that's where sometimes then that makes it a longer process, and it gets paid outside that 21 days, or gets processed, adjudicated outside that 21 days. And that's why we see the large interest payments there.
Thank you. I do have a question, if I'm allowed. So when we look at this slide, the slide, I think previous to this, or one of the previous slides showed like the enrollment by each of the three. Yeah. So when I look, so United has, it looks like about the same as Humana, maybe slightly more enrollment. But when you look at the claims that have come through back on the other slide, it appears that there are about half as many claims for United as there are the other two MCEs. Is that because those claims are rejecting up front and not making it into the queue, or why would there be so many fewer claims for them?
So could be a couple different reasons. I think that, because we experience claims issues from go live forward, Anthem and Humana are reprocessing a lot of claims, and adjudicating. So that could make their numbers, higher than United. And United did not maybe have as many issues, out of the gate as Anthem and Humana. We could take that back and give you a little bit more, like, I'm giving you the Holly off the hip answer, but we could take that back and get you a little bit more detail around that.
Okay, thank you. Are there other questions from anyone before we move on to Dawn?
There are a number of hands.
Oh,
in the
sorry, I can't see that, sorry.
Representative Clear and then Representative Shackelford, Senator Fedora.
Thank you. A few questions. So the enrollment slide that is slide 19, the 117,000 is total pathways enrollment, including the waiver, but not just the waiver, right?
Correct.
Total pathways. Okay. So how sustainable is the new quote unquote invitation level?
That's a great question. I think we are continuing to monitor how many individuals reject an invitation, go through the process and maybe do not qualify, either from a functional eligibility standpoint or a financial eligibility standpoint, because to go onto the wait list, you don't have to have gone totally through those eligibility processes. So I think we're going to continue to monitor what the yield is, but obviously the reason we've increased the invitations is because we want to help individuals get access to these services as quickly as possible, which is why we've sort of ramped up as we've monitored the throughputs and made sure that the overall system can maintain that level of invitation and all the different enrollment pieces, the role that the AAAs play, the role that our Division of Family Resources play on the financial eligibility side. We've noticed that we have additional capacity to add more invitations, which is why we've kind of ramped that up. So I would say we feel comfortable with where we are right now, and we'll monitor before we would make a decision to change from that current rate of monthly invitations.
And if I can add to that too, 40% of the folks coming off the invitation list are already in pathways. So they're receiving their Medicaid through the Pathways Managed Medicaid part. Now they're just adding the HCBS piece to that.
The waiver piece. Right.
Yes.
So what you just said relates to something I think I requested at the last MAC, and I'm wondering what the status is. I think we talked about tracking the outcome of everyone who is on the waiting list. What happens to them? There's some percentage who don't ultimately receive a waiver. So where are we with knowing what has happened to folks who aren't able to accept the invitation and receive the waiver?
I would say we're getting a lot closer on that data. It requires a lot of different systems that have a piece of the puzzle in terms of the financial eligibility system, the work that we hear and reports back we get from the AAAs. I think we don't have a subset of that data that we feel is clean data, so to speak, because of the different systems that we have to look at, but we are monitoring it closely. And that's really what's informing our increase in the invitations. And I think what we've really tried to do is continue to, as we get comfortable with new data sources, really included on that dashboard website to further, the delivering on our commitment for transparency in this space. So I certainly appreciate that. And I think it is one of the most critical pieces of the puzzle to make sure that when we're sending an invitation, it's actually resulting in someone going through the entire process and actually getting a service from a provider. And what we've seen is that takes time, and it took time before the wait list was in place and there was sort of this waiver capacity issue, but I don't think it had the same level of awareness amongst all of us, really.
How soon do you expect to be able to add that data to the dashboard?
I am not sure of a specific date. I don't have a specific date for that, and really would want to talk with my colleagues in the Division of Aging and our AAA partners before I could commit to that.
Ballpark?
I really don't have a
Can we get it,
ballpark.
can we get it before the end of the year?
You know, I really don't want to commit to anything, only because I'm not sure of what this is going to look like as we've added additional invitations, how that's going to potentially complicate the data. And what we also saw was when we started the invitation process in July, that was really not indicative of what this process looks like going forward, because we had these individuals who had been on the waiting list for a longer period of time. So I think what we'll do is continue to publish that level of care date, and that will really give us the next step into what could be publishing some more information about percentage then of enrollment. And of course, we do have enrollment data in our typical Medicaid enrollment reports that are available on the FSSA website.
Well, we're a little over a month away from the budget session, and I think it's critical information for the legislature and other stakeholders. So I would like to have that data before the end of the year and be able to understand what happened to people who were on the waiting list, on either of the waiting
Sure.
lists, Pathways or Health and Wellness, who didn't ultimately receive a waiver. So do you think it's realistic that FSSA can provide that data before the end of the year?
Certainly on the financial pieces of what this means as far as going into the budget session, we're doing everything we can to prepare that information, completely appreciating and anticipating we will get a lot of questions in this regard. I will definitely take the specific request that you have back, Representative Clear, to see if that's possible by the end of the year on the outputs of invitations.
Well, yeah, what I'm getting at is I'd like to know how many people were on the waiting list who didn't receive a waiver when they were invited. They no longer needed a waiver, were no longer eligible for a
Right.
waiver, and then break that down into categories. How many of those people had gone into skilled nursing? How many of those people had died? How many of those people had moved out of state? I mean, you know, I can think of a dozen categories, but that's what I'm getting at. Are we on
Okay.
the same page?
Understood. Yes, we are on the same page. And I think the different categories are where it gets just a little bit more complicated, and why we're trying to really think about, okay, how would we categorize the outcome of if someone is on the waiver? That's much more simple to determine than if they're not on the waiver, what was that reason? So that's the only reason I can't really commit to the end of the year.
Yeah.
But we will, we are actively looking at those exact questions you're asking.
And then I saw an ad for Pathways on TV the other day. I hadn't seen one for a while. We're still advertising Pathways, correct?
Yes.
So who-
Holly, do you want to chime in on that?
I mean, we have lots of people who are aging, still, aging in along the way, so, or they, where we talk about Pathways because we've got lots of people turning 65 too, who are already on Pathways as well. So we just want to make sure that they understand how that works, with their Medicare if they choose to, and so forth.
Is the state paying for those ads or are the MCEs paying for the ads?
MCEs may be doing advertising since we're in open enrollment right now. Our marketing funding for Pathways really was, I believe, the source of those funds was the HCBS enhanced FMAP dollars, and other one-time funding that we knew we couldn't put towards specific services without creating a cliff.
Speaking of one-time funding, I was also going to ask you about the status of the ARPA funding for resolving the waiting lists.
With the assisted living grants, is that what you're thinking?
Well, I mean, that's what you talked about making it available for. Before I had asked about making it more broadly available, because I think the population you identified that you have identified in the past is folks that already been approved prior to the April notification letter of the waiting list, right? Approved and in assisted living. But we have a broader population, you know, folks who want to stay at home and receive waiver services, and then folks who want to enter assisted living, but who weren't that far along in the pipeline as of April. So what's the status of the ARPA funding? How much is available and what population or populations will it serve?
Thanks for that question. So I think approximately $5 to $10 million is earmarked for that assisted living fund that you described around individuals who were residing in assisted living at the time that the wait list was announced. We can get some specifics. And in fact, this was a question that came up at the Medicaid Oversight Committee, and we shared that information with them as well about the remaining uses of those ARPA dollars. Really, it's a very small percentage of those ARPA dollars that are remaining after that assisted living grant opportunity has sort of run its course. I think, well, I don't want to say for certain. I believe it goes through the end of the year, but there's a team that's working on that. We can provide some additional information. But the remaining amount is a very small amount, but we're happy to provide that, and have provided it to some other, you know, public bodies as well.
Thank you.
Representative Terry, sorry, not trying to jump in here, but I'll just keep going in the room.
That's,
if that's
yeah, that's
okay.
great. Yep.
Okay, Representative Shackelford.
Okay, thank you for the information and the update. I just have two areas that I got concerns about. One is the member support services that's coming through a third party. Now, as I have helped seniors, and we call that pathway to aging line, that's that first step, I've noticed that those representatives really don't understand Medicaid. They don't understand the partial, they don't understand the full. One representative actually spelled out the QMB plus, and she said she didn't know what that meant, but she saw it on her screen. There's also no way for them to tell who the client's MCE is, which is usually what I'm calling for, because I just want to know, should I be going to Humana, Anthem, or UHC? And they don't see that on their screen, so they have no idea. It's very limited information when you call that number on what they actually know and how they can actually help the client. So I just wanted to stress that I don't know if additional training needs to be given to that third party. I don't know if the data in front of them needs to be changed, but somehow when seniors are calling that line, I think they need to get more information than what they're giving. What I end up having to usually do is just call every MCE and say, okay, is this your client? And they look them up and see, and they're like, no, then I'll go to the next one. And then I'll finally find which MCE goes to that client. Literally, that's the only way right now that they're able to find out. Whatever is being mailed, they're not reading it. I was like, whatever big booklet that they got from the MCE, because I've even copied all 3 booklets, put it on my computer. They're about 70 pages each. The seniors are not reading it. And so as I'm sitting there explaining to them and I see your logo, I say, whenever you see something from FSSA, open it, read it, make sure you're reading what comes through. But I think that first line of defense, like we really need to work on that third party and that number. So I just wanted to stress that.
Thank you very much for that feedback. And that's something I can see my team scrambling notes right now. That will definitely be addressed. Just for the sake of clarity, is that the 87 pathway 4 when they're calling the general pathways line, or is that when they're calling the member support services, which is really that escalation or ombudsman-like practice?
It's the pathway line.
It's the pathway
So the
line.
one that's
Thank
on the one that's on the brochure, and then when you go to the website,
That's the
number.
number.
Yeah.
Understood. We'll take that back right away. Thank you.
Okay, and then my next question also has to be on the pathway to aging, the waiver. I just need clarity. How many people do we actually have on the waiver? I don't see the total number on here.
That's right. That's not on any of these slides today, but we're happy to reflect it when we send this out. It's right about 30,000 individuals. So about 30,000 of the 117,000 Pathways members are Pathways waiver members.
Okay, so then my question is, if we have about 30,000 and we have 39,000 slots, why do we have about 8923 on the wait list?
So as of today, the open slots on the pathways waiver, which again is, we hesitate to say this number because it moves every single day by the hour really, but is right at 5,000 open slots, which is why we've increased the number of invitations we're giving out each month to try to exhaust all of our availability on the waiver to get as many individuals access to service as we can in a timely manner. So my
Okay.
30,000 may be a little bit of an outdated enrollment number, but we have 5,000 open slots.
Okay, and I think you told us before that you guys are taking, you boosted it up, because I think before you were taking like 800 a month, now you're taking 15. So I think one of the issues with that is the whole reasoning was because we were in that deficit, that $1 billion deficit, and we didn't want to fill those slots so rampantly. My question is about the $1 billion shortfall, because I just got a letter that one of our colleagues had sent to the Speaker of the House saying that we haven't got a full explanation on the reasoning for the $1 billion deficit and to make sure that that doesn't occur again. They thought they were going to get it during the Medicaid Oversight Committee on the 27th, but they still didn't get a detailed enough information. Do we have the reason why there was a $1 billion shortfall, and then how we're going to make sure that that's not going to happen again?
Thanks for that question. So in the December 2023 Medicaid forecast, which is available still on the state budget website, both the presentation and the reporting, we went item by item on an appropriation need or general fund basis, as well as a total expenditure basis to detail what had changed since the April 2023 forecast. Legislation passed last session that required us to also go before the Medicaid Oversight Committee and present this information, which we did in August, in a number of different topics, including both what were the causes of the deviation from April to December, which by and large was rapid growth on the aged and disabled waiver that became the pathways and health and wellness waivers. That accounted for about $500 million of the $1 billion alone that waiver did. And then we also went item by item on the other areas of that had changed from the time of April to December. We also presented in that August Medicaid Oversight Committee in great detail the steps we've taken at FSSA to ensure improved accuracy and reliability of the forecast. And certainly that's something we're greatly focused on right now as we get closer and closer to this December 2024 Medicaid forecast. It includes things like reducing the data lag and ensuring that we have as much data and as much recent data as we can to build trends and assumptions into how we forecast, as well as we've created a policy change review committee that reviews any change to a policy or a process that impacts Medicaid dollars to ensure we have a robust understanding of the fiscal impacts as well as the programmatic impacts, how it impacts our Medicaid members. We also have those monthly financial reports that are now published on the FSSA webpage that include detailed enrollment, expenditure, and funding information. All of those things we did following the December 2023 Medicaid forecast to ensure we're improving transparency and reliability of the forecast and how we then translate that into actual expenditures.
Okay, great. So two things. Can our committee members get a copy of that report that you presented to Medicaid Oversight?
Certainly, it's on the IGA website. We're happy to send you that link.
Okay. And then another thing is any legislators on your review committee, like when you're going over all this information, these changes, do you have any legislators sit in on that committee?
On the Medicaid Oversight Committee or?
No, you said you established a review committee. I'm assuming that's an internal review committee?
Yes, that is within FSSA, and it's comprised of division leadership across Medicaid, the Division of Aging, the Division of Mental Health and Addiction, the Division of Disability and Rehabilitative Services, our fiscal analysts, our finance team, state budget agency, et cetera.
Okay. Well, I would like to recommend that if you can invite a legislator to be on that internal committee, I think that will help bridge the gap between the legislators and then what's going on at FSSA, and they can act as a liaison. One thing I don't want to continue to see is FSSA get bashed. I know you guys are under a lot of pressure, and I know that it's a huge undertaking when you're trying to take on a whole project a new project and taking care of seniors. But if somehow we can just all work together, so it's not seen as so controversy and we're getting all these letters, I think that would be a good idea. So just a recommendation.
Appreciate your comments.
Thank you.
Senator Fedora?
Thank you. Do you mind if you go to the slide that had the number of open slots versus invitations? So can you one more time remind me how, so you mentioned we have about 8,923 number of individuals on the waiting list currently. If we continue at the same rate of 1,500 invitations per month, that roughly translates to about 6 months to process that, the remaining list, assuming you fully process 1,500 people a month. Is that accurate?
That would be accurate. But Senator, I also want to make sure I'm transparent and clear that there are only 5,000 open slots. So we do anticipate within this waiver year that there will be a point where, depending again on the uptake of those slots, we could run out of actual slots to even invite individuals until we get to July 1st of next year, and it's a new waiver year. So just want to make that
So to
clarification.
confirm what you said is that almost 3,923 individuals could potentially have to wait not on the Pathways program, but on the Pathways waiver list until July of next year.
It's possible. We don't know that though at this moment, because we have to, as we do the invitations, see who ultimately ends up being eligible and how that potentially decreases that number on the waiting list.
Is there a pattern of, through processing previous cases, of how many out of every 1,000 cases, for example, or out of every 100 cases or invitations, how many of those you were able to actually place in a slot? So this gives you maybe a model to estimate whether or not you will need 8,000 plus or 9,000 plus slots versus 5,000.
Thank you for that question. And that is the same data that that I mentioned to Representative Clear. We're really slicing and dicing right now to make sure we understand that and that we have a good baseline, because certainly in those first few months of invitations, one, we had a much lower rate of invitations, and there were a couple months there between April when the wait list was instituted and July where we were waiting to see how many of those individuals ended up accepting the enrollment. So after we have a few more months of data, we think we'll have a better baseline of what we call the enrollment yield, which is exactly what you've described.
My final question, as tagging along Representative Claire on this, we are approaching a budget cycle, and in the past, urgent requests were moved quickly in a session, especially if there was a sense of urgency to get them done as far as legislation. And I've seen instances where the General Assembly passed laws to allow state agencies such as the IEDC to augment the budget by asking for brand new money that was not approved by the General Assembly before. They just did that a couple of months ago. They've asked for 101 million, but the language was already programmed in law to allow them to do that. So my question to you, what is the model that you're using currently to accurately estimate the number of slots that are needed on a move forward basis? Because one of the problems that contributed to the $1 billion issue was the projections of demographics of people who might need the services versus the actual number that was approved, that was sent from the state to CMS to approve. Are we improving the projection model so that we don't run into an issue by which we are conservative in estimating number of slots and we end up being back in the same position of having 3, 4, 5,000 people that have to wait for 6 months or 12 months?
Yes, that's a great question. And yes, we certainly are. Now that we are looking so closely at this particular issue, I think it's given us a chance to really look at the modeling as well as looking at the aging population and what we know about the home and community-based services space, as well as we implemented rate increases and maybe other changes, access improved. And so that's allowed us to have better data to really inform, to your point, what we think the demand might be in this space. And then be prepared to, during the budget session, if there are requests for that, I would say requests for that type of fiscal information, we have confidence in fiscal estimates that we, would be able to provide.
Great. And my final question, and feel free not to fully respond to this, and maybe we can take it offline. But the state spending budget on the overall Medicaid program is close to $8 billion annually. we are contracted mainly with for-profit managed care entities that have to report to their shareholders anywhere between 4 to 8% annual net profits. So on an $8 billion budget, with the minimum calculation, you have about $300 million are just basically not the cost of service, not the cost of administering the programs, but rather profits going directly to shareholders of for-profit insurance companies. My question to you, did FSSA for any of these programs perform an analysis or evaluation to see if there are other open players in the market who are nonprofit organizations at a lower profitability margins that can help the state save more money and still perform and serve at the same level or even higher level of quality?
Thanks for that question. I don't have information available, or that's not something I've specifically looked at recently, but certainly happy to entertain discussions.
Appreciate it. Thank you.
Representative Garcia Wilburn, and then if it's okay, oh, sorry, Terry, go ahead.
No, that's exactly what I was just going to say. We've got about a half an hour left and we've still got three folks to present. So, but go ahead. I think you said there was another question in the room. Was there another question in the room? I'm sorry.
Yes, Representative Garcia Wilburn is, maybe move the mic a little. Yeah.
Can you hear me now? Online?
No, barely. I guess barely.
If you ask the question, I'll summarize it for those online.
Okay, perfect.
So I appreciate your response about the oversight committee on the 27th, and I know there was a robust PowerPoint concept. Are there any there an Excel spreadsheet or some sort of financial report that we can also look at that you might not have on your end?
That really, that sort of detailed line item reconciliation is what's in that December 2023 Medicaid forecast presentation, and that's on the state budget website. We're happy to, when we send out these slides, link to both the Medicaid oversight presentation from August 27th and the December 23 forecast.
Perfect, so we can reconcile them both. But then I have just another quick follow-up question in regard to the September report of the Medicaid fraud, up towards of 724 million that was reported. Is that somehow part of this budget shortfall at all, to your knowledge? Is there anything more investigation of the alleged misconduct of duplicated services not provided regarding the insurance companies that we contact with in the state?
And so you're referring to the litigation, the whistleblower.
Yeah.
And so obviously we can't comment on pending litigation, particularly want to call out that the state is not a party to that litigation. And so what I will say, irrespective of that lawsuit being filed, we have a robust program integrity team, both at FSSA. We have contractors who support that work. The managed care entities each have their own program integrity team that report metrics, and we have oversight of those processes at the MCEs. We're very dedicated to preventing and detecting fraud, waste, and abuse. And so we continue that work. I would say I have a fair level of confidence that it's not related to the $1 billion forecast issue. Although, again, I don't know the details of that litigation as we are not a party.
Appreciate your perspective. Thank you. Thanks.
All right, great. Let's move to our MCE partners. I want to thank them for being here and obviously their collaboration and great work. So we'll go through their slides fairly quickly here, but I think we're just going in alphabetical order, so nothing more regarding that. But first up, we have Don Butler from Anthem. So thanks, Don.
It's closer out. Well, good morning, everyone. Thank you so much for the opportunity to be with you here this morning. As Cora mentioned, my name is Dawn Butler. I'm the director of the Pathways program for Anthem, and delighted to share with you some of the updates of Pathways. Next slide, please. So our care and service coordinators have been conducting outreach, connecting with members to complete their health needs screens, their related assessments, and for those members that are receiving home and community-based services, working with them to update those service plans. Our outreach has initially prioritized focusing on those members who are receiving home and community-based services and living at home. We also are focusing on those members who are transitioning from a nursing facility, those members who are new to a waiver, as well as those that have an expiring level of care. In addition to our care and service coordinators conducting outreach, we also have health coaches that are connecting with members. And our health coaches are really there to help provide support to members as they begin their wellness journey and helping them identify some of their health goals. Recently, we had a member that shared that her health coach had, as they were connecting, she was initially a little reluctant to share some of her health goals. But over time, as they developed a trusting relationship, it really got into realizing that the member was hoping to lose weight and hoping to start to reduce some of the pain that she was struggling from. They began to talk about barriers that the member had been experiencing and then moved into helping to identify some healthy goals, as well as a food log and some healthy recipes that the member was interested in trying. After some additional support and discussion, the member decided to try physical therapy. And through that, she has found that she has been stronger, she's walking more, and she's reporting that she's feeling less pain. Not only has the member felt really inspired in sharing with the coach how helpful this additional resource has been, but she's also found another family member that has joined her now in her health journey, and they are grocery shopping together and making healthy meals together. Since it is November, I also think I'd be a little amiss not to talk about caregivers, as it's National Caregiver Month. But in addition to those members that I mentioned with the health coaches, we have caregiver guides that are connecting with our informal caregivers who are working closely with our members as well. These caregiver guides are providing that one-on-one direct support for our caregivers, helping to ensure that we are focusing on what's important to them, what matters most to them, helping to provide guidance on community resources, helping to make those referrals, and also helping to support the advocacy. Some of our early feedback from the caregivers have said, you know, it's really nice to have somebody call and check in on me. It's been a long time since someone asked me what my goals are or what I'm interested in. And I think that's really gratifying because ultimately we want to make sure that we are not only caring for our member, but we are extending that same care and focused attention to our caregivers as well. Next slide, please. So as I mentioned, our coordinators are conducting that outreach, and while they are doing so, whether that be happening over the phone or in person, they are providing their contact information so members can reach out and contact them directly. Additionally, members can have their coordinators' contact information listed on their care plan. It's also in the Sydney Health app that the members use, and they can always call our member services line. In fact, we encourage our members that if they have any questions or they're not sure who to call or they may have misplaced the phone number of their coordinator, so please contact our member services line as you see on the screen. We would be more than happy to assist them. Next slide, please. So one of our key focus areas as we are meeting our members is we really talk about the age-friendly framework, these pillars that are known as the 4 M's. And these M's represent mentation, mobility, medication, and what matters most. And the reason that we focus in on these geriatric syndromes is because we know that these are often items that are often unrecognized or under-recognized and can really impact a member's care. We were delighted to work with Socoa Aging and In-Home Solutions to help bring the Dementia Friends Indiana training to all of our coordinators. Socoa is the statewide administrator of this great program that helps to address the stigma around dementia and provide awareness around various types of dementia. And the feedback around this program has been wonderful. Next slide, please. I'd like to share a member experience that I think in part sort of highlights the need and the value of focusing in on those under-recognized and those under-reported geriatric syndromes. We had a member that when we met her, she was in a county jail. She wasn't required to be there, but one of the terms of her parole was that she had to have stable housing, and she was unable to secure that. There was no family and no other support involved. Upon meeting her, our coordinator quickly identified that Ms. X seemed to suffer from a cognitive impairment. We began to work with her parole board representatives and to have her fully evaluated by a geriatrics clinic where she received an official diagnosis of dementia. Once we had that diagnosis, we were then able to work with the Centers for At-Risk Elders to have a court-appointed guardian promptly appointed for Ms. X. Upon having that guardian in place, then the coordinator began to work with a number of facilities, helping to identify a place that would be best suited for Ms. X. And through this facilitation, helped to really ensure that all parties were meeting, we were gathering necessary paperwork, and making sure that we had everything ready for Ms. X when she was able to be transferred. We are pleased to report that despite some initial barriers, a facility was located for Ms. X. and she was able to be safely transferred and is now living in her new home and having all of her care needs taken care of. Next slide, please. Additionally, I'd like to highlight some of our provider support. Each of the providers that we work with has an assigned provider representative. This provider representative is there to provide individual support for providers. This can occur through office visits, telephone calls, or webinar meetings. Additionally, we continue to offer office hours, try saying that 10 times fast. And these office hours are alternating every other week between focusing on our HCBS waiver providers and then our skilled nursing facilities. The office hours really provide a wonderful opportunity not only to share information, but provide an open forum for providers to bring questions to the group and having a Q&A. Following each office hours, we always supply meeting minutes so that if providers have any questions or want to refer back to anything from that office hours, they would have the material to do so. Additionally, we continue to offer monthly webinar trainings. The webinars really are covering a range of topics from provider onboarding to the Care Central portal, which is a portal that's specifically designed for our HCBS providers, our Availity provider portal, as well as covering other waiver benefits that we've heard from providers that they would like to learn more information about. Additionally, I think as Colleen mentioned in her conversation, we are also meeting with provider associations and really having an opportunity to hear directly from them about any questions or concerns that we can help to address. We are also participating in the claims advisory work group, as Colleen mentioned, as really, again, an opportunity for us to come together and to hear any concerns from providers and being able to address those. We've also had the pleasure of being able to collaborate with our MCE colleagues and making some joint presentations to provider groups. Next slide, please. So as I mentioned, all the providers that we work with have an assigned provider representative. And so there on your screen, it just gives a breakdown of the territory map of those provider representatives and shares their contact information. Just as with member services, we have a provider services line. So if a provider has any questions, if they're unsure of who to contact, not sure who their representative is, they can certainly call our provider services line and we'd be happy to assist. And next slide, please. And lastly, just want to end on sharing a provider experience. Recently, we had met with an HCBS provider, and when she was first trying to submit claims, she was struggling a little bit with understanding how to set the portal up and set up her profile. Our provider representative reached out and met with her individually, walked through how to work with the provider portal, how to submit claims, and then helped her to resubmit those claims. As she was able to do that, then all claims began to process through the system smoothly. And the provider has reached out to the provider rep ever since then, just to continue to keep in touch and to say hello, invited them to some of the things that the provider was hosting at their facility, and essentially has really appreciated having that kind of extra touch and that additional follow-up from their provider representative. Next slide, please. And I think with time for, do you want me to shift to Emily and we could take questions at the end with that?
Yeah, I think it's okay with Terry. if it's
Yeah,
okay with
that's
you.
what I was gonna say. I think that's probably the best, if that's okay.
Okay, well, thank you very much. I'll turn it over to Emily.
Good morning. Terry, can you hear me?
Not real well.
Is this any better?
Yes, yeah.
Thank you. Well, it is an honor and a privilege to be here. My name is Emily Hayden. I'll speak to you. I am with Humana Healthy Horizons in Indiana. Just a little bit about me. I am actually born and raised a Hoosier, Southern Indiana, if you can't tell. And I have been in managed care for a little over 25 years. So essentially, as soon as I got out of preschool. So I'm going to talk to you a little bit about what we are doing here at Humana. So very similar to United. Oh, you can go to the next slide. Right. We are committed to seeing our members. We do have the same focus. We are looking at our HCBS waiver members, especially those that are at home, that really just, we need to make sure that they are receiving the services that they truly need. So we also have care and service coordinators helping our members. Every member, as a reminder, gets a care coordinator. And if you're a waiver member, you will also get a service coordinator. So our goal is to just make sure that they are living where they want. They are receiving the services that they need and that they are able to live happy and healthy lives at the location of their choice. We wanted to talk a little bit about Miss G. She is an example of a member, a 93-year-old woman who has multiple chronic conditions. She went and visited her family in Michigan recently. And while she was away, she actually had quite a few respiratory issues that caused her to go inpatient. She received a trach, and was intubated. And so Humana, our care team, stayed very, very closely with that member to understand exactly the services that she was getting in the Michigan facility, when she would be discharged, and what nursing facility she would be discharged to once she left. So as we talked to Miss G, we determined that due to her desires, she really wanted to stay as close to family as possible. So our care team contacted multiple nursing facilities, was able to find one that was suitable to her as well as be close to her family. And we worked to contact those and arrange that transportation to get her there, both evening, night, morning, all throughout the time. We actually did get into the facility around midnight, and we did confirm that she was able to get in there successfully. So while you might say that's your job to do, you are 100% correct. This is exactly what we are here to do. Just kind of wanted to reinforce that we are committed and happy to do so. I just kind of wanted to walk you through the phases of a typical HCBS waiver member and what that journey looks like. So once we are, notified, whether it's a brand new member that we received on July 1st or ongoing as we receive new membership, we will outreach and make sure we have that health needs screening phone call. That provides us a very high level look at what their physical and mental needs are. And then we will have what's called a conversational health literacy assessment tool. We have a chat, and that is done in person. And we basically find out and get a little bit more detail around the member specifically. We take all of that information to develop a person-centered service plan and help understand truly what is that member's specific goals and desires. Are they where they want to be? How can we help support them? And then we will make sure that they get their waiver services, any waiver services that they need, authorized. So we'll find out exactly what supports they have in the home, what are the needs that they are getting, whether that be through a family member or what is outstanding. So let's just take Miss G as an example. If she happened to be at home and maybe she just had an unsteady gait, she was fine with just about everything except for potentially maybe she just needed a walker. We would make sure she had the resources or tools to be successful at home and as independent as possible. We work to create this individualized care plan with the member, understanding all the services that we've determined were necessary. So we walk through that plan with the member, any of their caregivers, their primary medical provider, as a part of like an interdisciplinary care team. So once we have all of that put together for the member, we actually have ongoing follow-ups. So we'll have monthly contacts just to make sure everything is going well. We assess for loneliness, and then we will have quarterly in-home visits just to make sure that everything, again, continues down the path and they're meeting their goals that they would like. Throughout this process, we do have quality teams that audit these plans and just make sure that we are adhering to the highest quality as possible for each and every member. So just kind of the one to walk you through the process for each and every waiver member that we follow. Humana has completed the majority of our screenings and assessments for our HCBS members to date. One of the things that we wanted to continue to impress upon you is our diligence to working with each member and finding each member where they are. Sometimes that's very difficult to get a hold of these particular members. We actually have community health workers that we have on staff that assist us in case we have difficulty in reaching someone. So we're going to walk through another example, Miss J this time, who we called multiple times over weeks and months and she did not answer her phone. She just did not want to be contacted. And so we utilized one of our community health workers to go and find Miss J. We successfully located her and it was actually a very successful meeting. Ms. J was very pleased with that. In fact, I don't think she realized how much she needed that personal connection until we were in there and talking to her, really to get a feel for her desires, her goals, how is she doing? Through that visit, Ms. J has made a complete turnaround. She is continuing to see her doctor. She has both mental and physical impairments, but she is very happily engaging with our care team now and making certain that she's going forward. And she's experienced quite a few improvements in both. And she has moved to an assisted living facility that more is suitable for her and that she is happy with. Through our process as a whole, very similar to the other two MCEs, we will leave our contact information with the member. Our care and or service coordinator will leave their name, their cell phone, give them everything they have. If they don't remember it, if they misplace the information, they are obviously very welcome to call our call center. Just to, ask the information, we'll be able to assist them fairly quickly. Move to the next slide. Talking about our provider support model, we have both in-person and virtual sessions. On our website, we have a location where we have a training agenda, if you will, all throughout the next several months that include both virtual and in-person reviews. We've had very successful attendance. With my partner friends here, we actually had some annual seminars in October that had over 1,000 participants, individual providers that attended. So we are also providing virtual sessions. Humana has multiple sessions per week where we host, trainings and billing reviews, but we will also assist a provider if they just want to call and have an individual Zoom or, understand exactly what's going on potentially with their claims or their billing questions. We will do that as well. We have ongoing weekly meetings, as Holly mentioned earlier, with our associations. Those have been going very, very well. We truly appreciate the feedback so that we can continue to grow and improve. We can go ahead and move to the next slide. And this is a picture to show you that we have dedicated provider relations associates all throughout the state. So we're able to come and visit their offices if they wish. So we have emails that you can email to each person. We've also laid out who our provider relations associates are. They are partnered with a claims research and resolution associate to help them with any questions that they might have as they talk through their providers. We have dedicated associates for nursing facility, adult day, hospice and home health. And we also have our contact information. And if anyone wants to contact our claims and research associates, that email is on here as well. Our goal is that providers are not needing to contact us. Obviously they don't want to contact us. We don't want them to. We want them to spend the time seeing the members and not having to worry about any sort of, administrative work. So unless they want to call us and tell us, to have a wonderful day, that's ultimately where we want to be. We are committed to getting there. So thank you so much for letting me speak.
Thank you, Emily. And last but not least, we have Angie Eads with us from United Healthcare. Thank you, Cora. So as you will quickly recognize, I may be a little bit more south than Emily. I come to Indiana from Tennessee. I feel like I'm a native already. I've been here almost 2 years and I worked with United for a little over 12 years and definitely been looped in and immersed in the LTSS population. So I want to say, one, thank you for your time. And also thank you to our state partners. You have definitely supported us, and we walked hand in hand throughout this navigation of our Pathways program. So thank you very much, and to my MCE partners. Next slide, please. So we're going to start talking a little bit about care and service coordination and the updates that United has in this regard. And you're going to see here that we're talking about our independent care management agencies and our area agencies on aging. Pathways, as you've heard from Emily, Dawn, and Holly, it centers around person-centered practices. We are very passionate about our members having freedom of choice. We're providing continuity of care. And so that has truly been our focus, I can honestly say, for all three MCEs. So as for United, when we began our approach into the launch of the Pathways program, we revisited our appreciation of the valuable work that was being done in Indiana by our AAAs and by our ICMs. And we recognized they had established relationships with our Pathways members. And we really wanted to make sure that we partnered with our AAAs and our ICMs so that our members could benefit going forward from those relationships that they had established. We wanted a seamless, familiar transition from before Pathways into Pathways. So we made the decision, we wanted to make sure our members were put first. We wanted them to have that sense of security, familiarity. And so we contracted with 8 of our area AAAs and 3 of our ICMs here in Indiana. And truly that has paid off, not just for us, not for just our AAAs or ICMs, but for the members that we serve. And I want to share one comment that we received last week from SECOA, and it was about 3 members who had an established coordinator. Her name was Amy. And Amy had really been there for these 3 members and helped them navigate their path into the transition to Pathways. And they really relied on Amy. I think Amy had supported them a little over 2 years. And so when these members learned that we had contracted and partnered with SECOA, they were truly relieved that they would get to continue the support of Amy. And Amy really, I think, took their fears and concerns away about the transition into Pathways and the concerns that they would not be able to retain the established support that she had given them. So truly a win-win, but most importantly, it was a win for our members. And then we also have relationships with the AAAs who didn't choose to partner with us for service coordination. We are working with them, and they are providing support as far as nutritional supplements and our pest control service. So truly, the AAAs continue to be a support in the village it takes to bring this Pathways program to fruition. Next slide, please. So I'm going to share a member success story, and I want to kind of frame this up just a little bit. So we've talked about continuity of care and how important that is, not only for our members, right, but for our providers and for our caregivers. As Dawn mentioned, this is Caregivers Month, and truly they are the foundation of often the success of our members in a community setting. So well before the launch of Pathways, United decided to partner with CareBridge. And if you're not familiar with CareBridge, they provide a, if you will, telehealth service to members. And their focus is really on HCBS members. That's who they care for. And it's deeply rooted in LTSS, which is what we're bringing to the table here in Indiana. So it's a person-centered in-home medical behavioral health support that can be accessible any time of the day, anywhere that member is at, whether it be in their home, whether that be on vacation, whether that be in the home of a family member. CareBridge also, I just kind of wanted to give you an example of the support that they provide. They also provide support, as I mentioned, in behavioral health issues, but primarily what they see is issues such as UTIs. A lot of our members frequent emergency rooms, right, for those things, or after hours clinics. So CareBridge offers a service that is not replacing our service and care coordinators. It's really a wraparound service, and they're supporting not only our member,
but also our service and care coordinators. Additionally, they collaborate with that member's primary care provider, a specialty provider, their HCBS provider. So it's truly a holistic support to that member. And I'm going to talk a little bit about Miss Brown. Miss Brown is one of our she is a 60-year-old member, and she has multiple chronic health issues and has very limited support from her family. So as Emily mentioned, there's a process that our coordinators go through when they go out to see our members. And that starts with one, listening to our members, listening to their caregivers, and then identifying needs. And that's through assessments. And so one of those assessments that Emily mentioned was a chat. And our coordinator completed the chat with Miss Brown. And she quickly again recognized there was multiple health conditions, chronic health conditions that she had. And Miss Brown, throughout this assessment, said, you know, I'm just in the emergency room a lot. I see my primary care doctor a lot. I really would like some more time to myself, more time to spend at home. So through that conversation, the coordinator asked Miss Brown if she would be interested in this Care Bridge service. And Miss Brown was completely agreeable, and there was a referral made to Care Bridge for Miss Brown. She completed her first virtual visit with Care Bridge in August. And I want to say at this point, this was a July assessment. Miss Brown had been to the emergency room every month and seen her primary care doctor every month since April. So very important to know the end to this story. But as she made outreach to Care Bridge, she again made multiple outreaches, more so than monthly. However, again, it was an issue such as a urinary tract infection. Miss Brown had an ileostomy and had some skin breakdown. So she consulted with them as well, all from the privacy of her home. So truly amenable to her needs, meeting her exactly where she's at. Care Bridge then followed up every time that Miss Brown engaged them. They followed up with her primary care physician. They also followed up with her HCBS provider, her service and care coordinator. So again, a collaborative effort to make sure Miss Brown got exactly what she needed. Next slide, please. And I'm sorry, I should have put an end to that and I didn't. So I'm glad to say that Miss Brown since August has not been to the emergency room one time. And she has only seen her primary care physician when she had a scheduled routine visit. So truly a win for Miss Brown.
Angie, I'm going to interrupt just real quickly. I just want to make sure everybody's aware we're at time. So if you can just spend maybe a few more minutes, and I apologize for cutting you a little bit short, but we will make sure we get the slides out to everyone. And we also want to make sure we have a few minutes for questions, but so go ahead, but just want you to know
quickly. Yes.
Okay.
Okay. So talking about how you can contact your support and care coordinator, there's several different ways. Our care and service coordinator is going to provide that information to our member with their face-to-face visits and every telephone call that's made. They also have a person-centered support plan. That contact information for that coordinator is housed within that document. Also, they can reach out to our member services hotline. Again, they will connect them real-time warm transfer to that coordinator. And then if that coordinator is not available, they can leave a message to really close the loop on that process. Then our member services team sends an assignment to the coordinator and lets them know, hey, your member reached out today. Not only did they get that message, they got a reminder to reach out to that member. And then quickly, I'm going to talk about another success story. It's around our provider services team. This showcase, I think this member story showcases the positive results we have had through collaboration with our providers and our state partner, our commitment to serving Indiana Hoosiers, not just today, but ongoing. As you know, or you don't know, we completed claims testing with all of our providers before we went live with Pathways. And I want to highlight this provider, not for the fact it was an assisted living provider, but not for the fact that they had multiple rejected claims, but what transpired after claims testing. So this, as I said, this ALF provider experienced multiple rejected claims. our claims educator quickly identified that this provider was becoming very frustrated with the process. So they began one-on-one support. This one-on-one support evolved into so much more. It was a valuable partnership, not only that we could unravel the cause of the claims rejecting and to look at possible solutions for future claim submissions, but we also partnered with this provider to really look at how we could improve our processes, not only for our Pathways members and our Pathways providers, but most importantly, our members and their families. I can click next slide, please. Quickly, I just want to highlight some of the things that we've been doing here at United, and I'm sure the other two MCs as well. Weekly, bi-weekly meetings with our associations, office hour sessions, individually and collectively tailored to our providers' needs. Also, we have had a claims work group that has evolved into so much more than just a work group and sharing experiences. It is really looking at how we can navigate future work and future processes for the providers, the MCEs, and asking for and obtaining support from our state partners. Next slide. Here you will find contact information for our provider services team. I have also other contact information that I can share with Cora and Holly as well. Thank you very much for your time. Sorry, I was rushed there at the end, so thank you.
Sorry about that. We do. Are there questions? There are none on the line. I'm not sure if there are any in the room.
Yes.
Okay.
So I'll be brief, but this is another one of my concerns is our seniors being able to know who their care and service coordinator is. What I'm seeing out in the field, when I do call the MCE line, I'll give you one example. I called, we need to know who the service coordinator was. We're working with people on home and community-based services. They need help assisting with housing. The individual, the rep said she could not give out the contact information for the coordinator. She could only give us the name and she would take a message and relay that back to the coordinator. I asked, okay, well, how does the member know who their service coordinator even is? Did you send out a letter? She said, no, no letter was sent. So here's my concern, because as I'm talking to clients, as I'm talking to family members, they're being put in a situation where they're having to coordinate some of this care and some of these benefits. So my question to all the MCEs, for one, what is the status of everyone that's been assigned a care and community, a care and service coordinator, and has that assignment been communicated to the members? Where are you at on that? And then if we can get an aggregate report of this is how many clients that we have on Pathway, this is how many clients that we have on Pathway on the waiver, this is the percentage of who has been assigned, and then this is the percentage of who has been communicated or confirmed that assignment. Because I'm assuming that I know these members can be hard to get in contact with. I'm assuming that some of these members have fallen through the cracks and may not have or know their information. But I think it will better ease me if I can at least see the numbers and know where those gaps are and what can we do actually to continue to fill those gaps. And then the last question is, a lot of these members are so dependent on the AAAs and SACOA. And so they're continuing to go to them for their service coordination or their care coordination, not knowing if they have a contract or not with the MCE that they're with. So my question to Anthem and Humana, are you contracted with the AAAs and SACOA as UHC? And if not, how have you communicated that to your members?
Maybe we could just go very quickly. Anthem, Humana, United, and talk just a few sentences about your outreach to both your care coordination members and your service coordination members.
So thank you for the question. So first off, our member services line is able to give the contact information for the coordinators. If a member calls and they have not received that, please I'm happy to talk to you afterwards, but let me know. But our member services line, so if a member calls, they are to receive that coordinator direct contact information. I know you mentioned earlier the likelihood that our members are receiving letters, but maybe haven't read them. We are sending out letters with that contact information as well. So when that assignment is made, a letter is generated to let them know who their coordinator is. But again, recognize that that is not always the best method of communication. We are very cognizant of making sure those assignments are made and are made very quickly. So we are conducting that outreach and again, getting all of those members assigned. As far as your question around, service coordination, we are not contracted with SACOA and some of the other AAAs, but we have, as Angie mentioned, in a similar vein, have been working with them on, one as a provider of services and also looking at some of the other offerings that they have in the community that have been really beneficial to our members. But we are working closely with our members and ensuring that they have the contact information from the coordinator, ensure that we are working on that continuity of care, and then working with the AAAs and so on to make sure that we are having a good communication if there's a transfer.
Okay, and then the status, where are you with your assignment? Has everyone been assigned?
Yes, I don't have the numbers with me today, but yes, our assignments are made.
Okay, I would like to get some numbers. Thank you.
So I'll want to echo what Dawn said as relation to calling in and getting that coordinator information. They should be able to give that.
Can you speak in front of the microphone?
Yes, so sorry. So I was echoing what Dawn said, as in if someone calls in and wants to know their coordinator's contact information, they should be able to get that from our member services line. If they're not, I'm like Dawn, I would really love to entertain that conversation. We definitely don't want that to be a barrier to our members or family. We too are looking at our assignments. I will tell you, we've engaged around 80% of our members already, and then a little, almost 20% of those members have been unable to reach. So there's many methods that are processes that go into unable to reach, such as multiple telephone calls, in addition to driving to a member's home. So we are definitely working to, as Emily mentioned earlier, go above and beyond trying to make outreach to these members. And for assignments, we have created assignments to all of our membership as well.
Okay, thank you. Thank you for that data.
Yes, ma'am.
And this is Emily. Can you hear me?
Yes.
Okay. So yes, 100% of our members are assigned. Members can contact our call center to find out if they don't already have it. We do send out letters. In fact, our care information is on like our service authorizations as well. What we can do also is just to reconfirm and reply numbers later, just to ensure like every letter has gone out. But we have made outreach calls to everyone. Again, except for maybe the ones that we have not been able to reach, and we continue to attempt to do that and use our community health workers. So the only time, if you contact the call center, let's just say their service coordinator happens to be out in the field, we will take that information and we will have another care management team contact the member right away just to see what services they need, but also make sure that their care team has the information to call them back as well.
Okay, so you're 100% assigned for care and service coordinators?
We are.
Okay, thank you.
And Representative Shackelford, we also monitor and do secret shopper calls to verify the information that you were just bringing up as a concern, to ensure that we can call under, a member and say, tell us who is the care coordinator assigned, the service coordinator assigned to those members. So we've been checking that, and to date, they've been compliant with that requirement.
Okay, great. Thank you.
Are there other questions in the room?
I don't believe so.
Okay. Then are we ready to adjourn, Cora?
I believe so.
Okey doke. The meeting is adjourned. Thank you all.
Thank you.